So like you probably know, we every year the R5 are presenting about one of the Cardinal Topic Rosen chapter. So I chose chest pain. Sorry, my cat is playing. I'll just, give me 1 second. All right, sorry about this. It's gonna be easier that way. So chapter 23, chest pain. And I just tried to copy paste the whole chapter in a word cloud to see what it would give me. And this is what it looks like. So I thought it would be helpful for the presentation. Honestly, covering something like chest pain in a 30-minute talk is a little bit difficult. I thought it would be easy. I was like, chest pain, we do that every day in the emergency department, no problem. We're expert in chest pain, but this is trying to put together a presentation and realize this is a very broad topic, and with a very wide range of presentation and diseases, and with some that are very acute and some that are very benign. But this is something that we need to be very good at. And the way I organize my presentation, instead of going through the Rosen chapter and presenting you table and figures about their algorithm, I just decided to put together a few cases. I have 6. I'm not sure we're going to be able to go through all of them, but we'll see where we get. Just to warn you, they're not diagnostic dilemmas. They're not hard cases. I just tried to put together in the cases the kind of like typical presentation, just to kind of have an idea of like, what is this typical presentation, and we'll discuss quickly for each case some diagnostic strategy, initial management, and hopefully there's a few clinical pearls that you can bring back to your next shift. So I'm going to have a few questions during the presentation. I invite you to put your answer on the chat, or if you want to try to unmute yourself and give the answer out loud, but we'll try to go quickly on that, so the chat is maybe easier for that. So my first case is a 55-year-old man that is brought to you for crushing chest pain, smoker, diabetic, and obese. His vitals are there, he's a little bit hypertensive, but otherwise not too worrisome. He has a substernal squeezing chest pain that is radiating to both arms, and he's nauseous, and he vomited once. He's pale, diaphoretic, and he looks uncomfortable. The pain was not relieved by nitro. So this is the ECG. Anyone want to try and answer? What do you see on there? Concerning, not concerning? Anyone in the chat? Oops, sorry.
There is ST elevation in lead 1, V1, V2. And as you can see as well, minimal ST depression in lead 2.
Yeah, very good. There's the beginning, we can guess it's starting to raise in V3, V4. We also see some hyperacute T waves that are a little bit worrisome, and with the story, it's certainly worrisome. So basically, you're concerned for acute coronary syndromes. So you put your patient on your monitor, your IV access. You're going to give your patient aspirin. You do your labs and send a troponin, chest X-ray, your POCUS as well, and you repeat an ECG. And this is the same patient a little bit later. So what do we see now, and what's your diagnosis? Cat lab, yay, code STEMI, very good. So you have an enteroseptal STEMI, and so V1, V2, V3, V4, mark ST elevation, and you can see also in the inferior leads, there's ST depression, so your reciprocal change. So you call cat lab, you call your cardiologist, depending on where you are. And your aspirin is already given. Just to note that aspirin is probably one of the most useful things that we can do in the emergency department, with the number needed to treat to prevent death of 42. You send your patient for a PCI if you have access to that. If you have the chance to go in a more rural center, it's always interesting if you have a STEMI like that to do thrombolysis. There's a little bit more of a stressful component to it, because you're kind of like pulling the trigger yourself, and it's not the cardiologist who's going to have the final word on this. Just note as well the thrombolysis for this is an NNT of 43. Those numbers are coming from the website nnt.com.org, I think. It's a very good resources for evidence-based medicine. If you have any question about this, you can let me know. So the patient was a little bit hypertensive. You could start the patient on a nitroglycerin drip if you have time, or if there's going to be any delay, you should be giving a little bit of analgesia. Depending on your local protocol, you're going to give a second antiplatelet agent and heparin. And just note as well that the anticoagulation is also a little bit controversial in terms that it doesn't show really clear benefit in terms of like strong outcomes, and it does have some associated risk of bleeding. So you should certainly be looking for contraindication or high risk of bleeding with your patients before giving them that, and discuss this with your cardiologist as well. So acute coronary syndromes, when I was talking about the Rosen figure, this is one of the examples that in the chapter 23, and it's probably better that you read it yourself if you really want to understand what they meant by this. But basically, the kind of like key messages that I have to that I want you to remember is that there's atypical presentation for ACS are very frequent in the emergency department, and we constantly have to be on the watch for this. It can be someone that like comes with some kind of like GI symptoms. It can be someone that comes with only shortness of breath. So be on the watch for ACS. Aspirin is the most useful thing. Your troponin are going to be very site dependent, and this is a little bit how to interpret them. You kind of like need to be looking at your local institution and what they do in your labs. And serial EKG, like you saw in this case, is going to be very helpful. And you can see that sometimes things are evolving, and it's always worth repeating your ECG after 5, 10, or 15 minutes. If you have any doubt about the ischemia. Also, you kind of like, we do a lot of low risk chest pain. That was like a kind of like MI, but you need some tools to be able to risk stratify patient in the emergency department, because this is not true that we can ask for cardiology consultation for every patient in the ED. I think the heart score is probably one that I use the most. It's very useful. It's very reassuring when patients have a low score of 1, 2, 3. You can send them home with an outpatient follow-up without any problem, because it's shown that 0.9 to 1.7% of risk of major cardiac event. So it's probably a very good tool to use for those who don't use it routinely. I would encourage you to go read a little bit about it. So what is the approach to chest pain in general? I'm not going to teach you anything in those 2 next slides, but I think the careful history and physical is very key. And obviously, any patient that you suspect any discomfort to the chest going from the neck, arm, and kind of like probably belly button, you should be considering an EKG. This is something that is very low cost, easy to do, easily accessible, and it can give you very precious information. I think chest X-ray still does have a role in chest pain depending on the circumstance. It's not going to help you with ACS, but it can help you exclude other diagnoses. And as people are getting more and more comfortable with POCUS, POCUS has certainly a very important role in the investigation for chest pain in the emergency department. When I'm talking about careful history, this is like the OPQRST for pain, and I didn't put that over there to teach it to you, but more to remind you that really when patients have risk factor like hypertension in the emergency department, this is not really helpful to us. The clinical presentation is way more helpful to determine the pretest probability or the pretest probability of having a disease. And this is really like those features that are going to help you. And the fact that the patient is a smoker or has hypertension or diabetes, in a more epidemiological way, it's going to help. It's helpful to make studies and to make to see who's at risk, but it doesn't really change the pretest probability of the patient that you have in front of you. So yes, you can ask those questions. You should be asking those questions, but keep that in mind. And just to illustrate a little bit this to you, those numbers are from Essential Evidence Plus, and those are the likelihood ratio. I mean, there's like 3 pages of different feature associated with chest pain that are going to increase or decrease the probability of the patient in front of you having chest pain. And most of the classic risk factor are not in those, don't have a high likelihood ratio. So really the things that are the most impactful are radiation to both arms, well, third heart zone if you want to listen to it, but radiation to the right shoulder, chest pain that is to the left shoulder, previous MI, crackle, diaphoresis, and things that are going to decrease the probability of having an MI are things that have a likelihood ratio between 0 and 1. So stabbing or sharp chest pain, positional chest pain, reproducible by palpation, but nothing is 100 absolute %. This is just increasing or decreasing. And note that the serial EKG is a likelihood ratio of 136. So it's the thing that was the most, the higher in the list of things. So second case, you have a 14 years old female, no past medical history, no OCP. She presents with the pleuritic chest pain and shortness of breath for 2 days. She noticed that her heart rate was above 120 since then. At triage, she has a pre-syncope. Her heart rate is 130. She has a low BP. She's tachypneic and desatting. So obviously, I think you know where this is going, but this is her EKG. Anyone wants to take a try at interpreting what do you see? COVID, yeah, no, try again, something else. What do you see on the EKG? All right, so I'll try to go with this. So there's obviously tachycardia, sinus tachycardia, thank you, T-wave depression, and there are in mainly the anterior leads, so maybe some right heart strain. And if you look, there is maybe the beginning, yeah, S1T3, so the beginning of a S1Q3 T3. The Q3 is not there yet. So you put your patient on monitor again, IV access. The mother is telling you that she's known for antithrombin 3 deficiency. The physical exam is otherwise unremarkable. And when you do your POCUS exam, you have a right ventricle that is maybe twice the size of the left ventricle with a dilated IVC. The BP becomes a little bit normal after your IV, some IV fluid. So you're able to send the patient for a CT scan, and it shows a large saddle embolism that occludes almost 90% of the right pulmonary artery. This is a kid I saw at the children. It was a very interesting case. They don't see a lot of PE at the children. What would you do with this patient? Anyone want to attempt an answer? Embolectomy versus thrombolysis. Yeah, very good. Because she had hemodynamic instability, and because it's a very large, very massive pulmonary embolism, this is certainly something that you would consider with your ICU, your consultant. So for that case, we started the patient on anticoagulation, and we discussed with IR, and they went for endovascular thrombolysis. And it worked very well. The patient was admitted to PICU, but she had a full recovery of her cardiac function within 5 days of the event. So pulmonary embolism, you all know about the Wells score and the D-dimer. This is a way of risk stratifying your patient when you see them initially in the emergency department. And again, on Essential Evidence Plus, the likelihood ratio, I found that very interesting, of a clinical assessment done by an attending was 3.3, which is one of the factors that have the most impact for the case of pulmonary embolism. So I think we can say in general, like kind of like clinical judgment of someone with experience is pretty reliable, but like as you start, like using the Wells score is a very kind of like objective way of risk stratifying your patient. Using something like PERT rule as well is very useful, because if you have 0 criteria, you have less than 2% chances of getting a P. Investigation is usually done with the CTP. In rare instances, you can use a VQ scan. I haven't seen a lot of those recently, but it was sometimes in rural center or in smaller center when there's a difficult access to CT, you'll see that still. There's multiple options for anticoagulation, so you should be talking to your consultant and the people that are going to be following those patients to consider to decide on which anticoagulation to give. And finally, thrombolysis. This is not something benign. There's a lot of complication, and the number needed for harm is 10 for major hemorrhage when you do thrombolysis, and the NNT is 34. So this is certainly, this is for systemic thrombolysis, but this is certainly something you need to keep in mind if you're gonna think about thrombolysis. I don't have the number for endovascular procedure, but I'm expecting that it would be much less than this. What was the rationale used in choosing in situ thrombolysis rather than surgical embolectomy? Was it because of her hemodynamics? So actually, this the rationale for that was, first of all, IR is a little bit less invasive, I would say. Second of all, the radiologist that read the CT scan was an interventional radiologist who came to see us in the emergency. And while reviewing the scan, he was like, I think I can go and like get the clot out of there. So it was kind of like the default option in that context. And I think this is yeah. That was the rationale. Hopefully it answers the question. So third case, 18 years old, presenting for right-sided chest pain and shortness of breath, no previous medical history. He's very tall, maybe Sept's height, and thin. And he's dyspneic and has difficulty completing full sentences. He's tachypneic, hypotensive, has a high rest rate, and he's obviously in rest distress, and he has decreased air entry on the right side. So you still decide to do a chest X-ray, and this is what you get. Can anyone tell me what is very wrong about this chest X-ray? Large mediastinum, sure. That it exists. Thank you, Dr. Richard. Yes, that's exactly my point. This is a tension pneumothorax. So you have a large pneumothorax on the right, and you have shift of the mediastinum a little bit to the left. And with the clinical picture that you add, previously, you should not be doing a chest X-ray. You should be intervening on that. This is obviously a tension pneumothorax, so it's a clinical diagnosis. You should be decompressing the chest with a finger thoracostomy and putting a chest tube in, or using a needle decompression if you don't have access to a scalpel maybe. And after get your chest X-ray when the patient is a little bit more stable than this. For pneumothorax in general, remember that there is a differential diagnosis for the absence of lung sliding. For example, if you had a patient that had a previous surgery, there can be some adhesion of the lung to the pleura that would prevent lung sliding. So this is not because there is no lung sliding that you necessarily have a pneumothorax. You have to be looking for the lung point. In the otherwise healthy patients, small primary pneumothorax can be observed with repeat chest X-ray to see if it improves, resolved, and if it doesn't, or if it's a larger pneumothorax, you can consider needle aspiration, pigtail, or chest tube. I don't know if any of you have ever done or seen needle aspiration for pneumothorax. Personally, I have not, but it was interesting to read that it was an option in the Rosen. So I don't know if people are still doing that really, or if you should be just draining it with a pigtail as it's getting more and more available and accepted. So next case, 50 years old with previous medical history, no previous medical history, is presenting to you with excruciating retrosternal chest pain radiating to the neck and both shoulder. The patient has been retching and vomiting today. He thought he was having food poisoning, but now with the chest pain, he's not sure about this anymore. His vitals are relatively normal, and on physical exam, there's subcutaneous emphysema on the chest and on the neck. So you have this chest X-ray. Anyone can describe what they see on there? I don't know if the picture is easy to see on your screens, but I think you can probably. Where is that focus? I don't think I have focus for this. There's much air in the neck, pneumomediastinum, exactly. So the diagnosis, you make a diagnosis of Boerhaave syndrome, exactly. So esophageal rupture. Remember that there's many etiology for this entity. Sometimes it can be iatrogenic after a scope or another surgery procedure. Sometimes it can be from a trauma, either esophageal foreign body or external trauma, stab to the chest. But it can also be what we call the Boerhaave syndrome, which is a kind of like sudden increase in intraesophageal pressure combined with the negative intrathoracic pressure that is going to do some tearing and perforation of the esophagus. It's usually associated with vomiting. But it can also be with severe straining. Sometimes they also describe with childbirth, seizure, prolonged coughing, and even weight lifting. So anally, you should be careful with this. They say, I was surprised about this, but they say that up to 25 and 45% of patients don't have any history of vomiting for the Boerhaave syndrome. So this is something to keep in mind. This is something that there's often delayed in diagnosis, and if it's left untreated, it can lead to a very high morbidity and mortality with sepsis and organ failure. So you should be on the watch for this, even if it's something that is relatively rare. You diagnose it if you with either esophagram. You should be starting with gastrographin because it causes less inflammation if it kind of gets out of the esophagus. But if you don't see anything on your gastrographin, you should be going with a barium swallow after because it's way more sensitive. But this would be, I think, more in the context that you don't have access to a CT scan. CT scan is going to give you, it's very sensitive for extravasation of the contrast, but it usually doesn't show exactly where is the leak or where the tear is. So esophageal rupture is treated with like basic resuscitation, antibiotic, and the patient should be admitted for monitoring and to kind of like possible surgical intervention eventually if it doesn't heal or it's too big. Remember also that esophageal rupture can have multiple presentation depending on where the tear is. If it's more in the lower part, it may give more abdominal symptoms, and if it's more in the kind of superior part of the esophagus, it may give more like neck pain, difficulty swallowing, more of a upper symptoms as well. Next case, and your colleague resident comes to tell you that he's having chest pain. It started yesterday, but now it's getting worse. The pain is dull. It's worse when he's laying flat, but it improves with sitting. He has no past medical history. However, he reported the recent URTI. He was afraid he was having COVID, but he got 5 negative swab since then. So you kind of try to auscultate him, and you think you are maybe hearing a friction rub, but maybe it's also the negative pressure machine that is doing noise in the background. So you decide to get your ECG and your POCUS machine, obviously. And this is the EKG you're gonna get. So who wants to give a try at that EKG? Just write what you see in the comments in the chat. Diminished PR, ST depression, PR, okay, all right. So we see kind of like diffuse ST changes. So yeah, if you look, there's kind of like a diffuse ST, I don't know if you see my mouse, but the ST elevation and some PR depression as well. If you look in the AVR, you have the opposite, so reciprocal changes in AVR. And so you make, you get your ultrasound, and this is what you're gonna see. So there's a pericardial effusion, and with those two, you make your diagnosis of pericarditis. And you are still gonna send your labs. The CRP is a little bit elevated and the trope is negative. So you're going to start your patient or your colleague, I would say, on NSAID and colchicine, and you're going to discuss the case with the cardiology team to arrange for some follow-up and formal echo. And so this is for pericarditis. For making the diagnosis, you should be having 2 out of those 4 criteria. So the typical chest pain that is worse supine, better sitting, that is kind of like dull. Maybe a little bit of like pleuritic component to it as well. There's a pericardial friction rub is in those criteria. ECG changes that are suggestive are of pericarditis, and then new or worsening pericardial effusion. If you get a troponin that is positive, then you're going to call this a myopericarditis. And note that about 1/3 of the pericarditis, idiopathic pericarditis, are going to have involvement of the myocardium as well. We often do ESR and CRP, but I was kind of like surprised to that. I thought it was kind of like part of the diagnostic criteria, but like it's not sensitive or specific. So even if you have a negative CRP ESR, you should you can still have a pericarditis, obviously. And finally, this is a question that always come back. So it's worth learning this in your first few years, because you're going to be questioned about that all the time by staff. So what are the 4 stages of changes of EKG and pericarditis. Well, the first stage is, as we said, widespread ST elevation with PR depression and reciprocal change in AVR, sometimes V1 as well. In your week 1 to 3, you're going to have normalization of the ST segment and generalized T-wave flattening. Stage 3, after 3 weeks, usually you're going to have T-wave inversion. And finally, after several weeks, you're going to have normalization of the ECG with T-wave that may become inverted permanently. Just note that even if we kind of like learn those 4 stages and like need to know them, it's less than 50% of the patients are going to follow the typical pattern. So with this, I just completed my 30 minutes, so I'll be done with my presentation. Is there any questions in general or comments? It was kind of like an overview of the typical diagnosis that we have. Hopefully it was helpful. And Josh says, I remember a talk from the GGH cardio specialist in pericarditis where he started is never seen a patient with pericarditis with a normal CRP unless patient was already treated with NSAID. Referral bias at play, but interesting observation. Yeah, that's totally true. And maybe also we can, maybe patient also sometimes take NSAID before coming to the emergency. When they have some pain, they try to resolve it, to resolve by itself. But of course, we tend to cardiologists and other specialists tend to see the worst cases and that we send them. Any other comments? So I think Audrey, I'm going to be done. Monica, I've also had cardiologists from MUHC say the same thing. All right, I don't know what to argue. I'll have to go